The best part of Oxford is right patient selection and followed by the right surgical technique. There is nothing like my way of doing surgery again. Across world, each one is doing it the same way, same steps every day. So let us summarize the problems, what is most worry the surgeon. Number one, tibial, this is bearing dislocation. That is like mobile bearing means dislocation. The ratio is 0.1 or 0.05 in a literature if we study it. What I am concerned in our patient is a tibial condyle fracture. I think that is most worrisome. Be careful with this. And if you do not respect the soft tissue, you will have a progression of arthritis. If you release inadvertently or you overstuff the middle compartment, you will have a progression of lateral compartment arthritis. These are the worst nightmares when you think of a uni as a surgeon. So let us go back to the important aspect. Keep faith in simple things. Do not compromise in X-rays. It's all needed in most of the cases. MRI is not required. It is like a self-inflicted wound you give to yourself. So if you don't want to do uni, go for MRI. You have 100 reasons not to do a uni. Relative contraindications already discussed in the first case. They are the pseudo-relatives of your mind. Neither they help you nor they leave you. They just stay in your mind. Patient seems obese, patient seems elderly, patient seems young. If it is AMOA, then it's uni. That's it. So on-table decision is an exclusion. You cannot go all the time that I will take on-table decision. It is an exception, like 1 in 100 case. It may be a possibility. Otherwise, right patient, right position, right execution, and right functional outcome. So best part of Oxford is a coronal plane is your plane. As a surgeon, what exactly you do as a surgical technique? So you just do arthrotomy. You remove the half of a fat pad. You do a vertical tibial cut in a coronal plane. You do a meniscectomy and do peg holes. That's it. You cannot do anything else even if you want to do, because entire sagittal plane is taken care by the instrumentation system. So that is very important and easy to understand. So coronal plane is your plane, sagittal plane is instrument systems plane. About the sizing, it's very simple. It's gender and height specific. So extra small is something when you use the lowest or the smallest TKR you have in your mind, like size 1 TKR, use extra small. Even if you use small, it doesn't matter. All female average height is small, all males are medium, and very tall male, when you are thinking about the very large TKR like size G, then you think of a large size femur. This is so simple. In 99% of patients, you will have a small femur, B or A tibia. You will have a medium femur, C or D tibia, and 3 or 4 bearing you need. So this is an example of the least inventory you need when you perform the uni. It's very simple. So let us understand the surgical steps. I have deliberately made it very colorful so that we can easily remember it. Life begins with a color code. So boys are blue, girls are pink. So all the trays, when you open, when you go in, if you see red, this is female patient, and every instrument has a red mark. All the time medium femur, male patients have a blue landmark. So every time your eyes are trained, even someone has made a mistake, as a surgeon, you can easily identify it. Why Oxford position? Why hanging leg? It makes a lot of sense. It's a gravity-assisted surgery. It is AMOA. It's not rheumatoid, not post-traumatic. There is nothing you can do. You can't release deep MCL in uni and correct. It's not for correction. It is feeling, and by feeling the hand. So it is hanging leg, gravity-assisted, plus your gaps in TKR is 0 plus 90. In uni, it is 20 plus 190 is equal to 110. So it is natural hanging leg position, and you just feel the gap without stretching the ligaments. The only important message is pose to expose. Do not do external rotation. Do not release any soft tissue. Think you just need to put a tibial jig. That's it. Your thought process is changed completely here. And the lesser you open, more you are in the center, avoiding varus and valgus placement of your jig. Even it's a dual mobility hip, so 5-degree varus and valgus doesn't make sense. Just remove the osteophytes. There are 4 osteophytes, 2 on femur, 2 on tibia. And then you are basically starting with your balancing technique. Now the most important and intellectual part is you need a reference. What you reference when you do uni. So the posterior condyle of a femur is the only native landmark left because it's a correctable varus, flexible varus. So that's why you use it. You use a spoon not only to reference but to balance the knee before you cut the tibia. So the spoon varies in size of 1, 2 and 3. You can plan your execution in millimeters like 3G or 4G, and you will have a consistent 7 degrees of slope. Otherwise, do not change in any case. You don't need to change any case. It's always 7 degrees in every single time. Do not cut the posterior cortex of a tibia, otherwise it will have a catastrophic complication. So now if you see the tibia is terrible, femur is fantastic. That's the one line statement for uni. Spend time with tibia. We will have a spoon 1, 2 and 3. We have clamp 3G and 4G. We have slotted shim, non-slotted shim. The more you do, more you understand, but ultimately you can plan. Like I have a 120 kg female. So I know she is 120 kg female. I am operating on her, very small bone. I have 48 ways to plan my tibial cut. So once you know the system, how it works, there are more modularities you can plan and avoid the catastrophic complications. Always plan a thinner tibia, avoid thick tibia. So this is the most important message, the Gnan Mudra. That means you never force anything inside the knee. It should go in hand with very simplicity. If you cheat yourself in the beginning, it will cheat you at the end. Never hammer, you will have a fracture. This is the posterior condylar cut. Most important, do not undercut it. Otherwise there will be a tight flexion gap and your uni, your bearing will not go at the end. And you are surprised why it is tight at the end when I have done everything fine. The posterior condylar cut is a problem. So spigot is a wonderful science you have to understand, because any flat surface you can cut with a saw, concave surface you can always use a reamer, and convex surface you can always use a miller. This is the scientific and easiest way. Never ever hammer the spigots, third spigot, because there is a collar that you had removed. There is indirect, very intellectual reference point inside created by a drill bit, so never ever hammer it. Always remove retractors when you balance your knees, because if you stretch the soft tissues, it is a gap. That's why the hanging leg position is a sensible way to fill the gap without overstretching your ligaments, and it makes surgery very sensible. So Oxford says you plan your luggage first, then you plan your bag. So my luggage is my flexion gap, my luggage, this bag is my femur. I do a 0 spigot, I will make it round. It's a gesture to start packing. If you are lucky, you will get away in 2 spigots only. But if you have a more luggage at the end, you have a third spigot that you can utilize by 1 millimeter increment. So every millimeter you plan has to be perfect, balanced knee in flexion and extension. It is a very simple science and you have to just learn it. So once it is done, so everything as per the flexion gap, created a recreation of extension gap as per the flexion gap, and you are ready to go. So this is the same step. You cannot change it even if you want to. Make sure your feeling gauge is perfect. So I'll just show you a video rather than going for this. Remove the osteophytes. Impingement is very important. Tibia is all about aligning the femur and the poly in the room. This is my own case, impingement, and you can see why the bearing can dislocate. If you make an error, then only it will dislocate. Cementing is very important, and this is just I want to show. This is 2 millimeter loose. No one will have variation between surgeons across the world. Everyone says this is loose. And same in the extension, if you see 2 millimeter is loose. Very sensibly you can stretch and balance your ligament without overstretching. So 4 millimeter is not going inside. So you don't need to measure the actual bearing size. One below and one above will confirm it. If you want more information, then you use the right bearing and you will have 3 different perceptions. So tight, standard and loose. So 0.3 millimeter precision on your fingertips, and that is a well balanced uni without overcorrecting. And that's why it doesn't go in a lateral compartment arthritis. If you have a tendency to make it tight, you stretch the ligament, you release the deep MCL, and then there's a problem. AMOA is not for weeks or months, it's there for 7-8 years, you can say. That's why just a recollection of vigor. So patients come to you, you can amply say that you have ample of time, plan your surgeries, there is no hurry. So take home message, do not release. Uni is a bony procedure with utmost soft tissue respect. Each instrument is uniquely designed. Understand them very well. Do not explore my way of doing surgery. There is always a right way of doing surgery. And results are technique dependent. Learn the right technique. Tibia is terrible, femur is fantastic. Spend time with tibia. Balance 1 millimeter in extension. Impingement is very important. Our patients use Indian toilets, they sit on floor. So make sure you remove the posterior osteophyte, otherwise the bearing can dislocate, but if you do well, it will never dislocate. And Oxford is a technically demanding procedure, but intellectually very exciting procedure. Start from the indication. And if you plan to do it in good numbers. Once in a while, if you do it, you are inviting complication, your staff is not trained, the instrument can fall on ground. So if you adopt it wholeheartedly. So average 20% is the minimum. If you extend, you can extend it better. And all the study says, if you are doing it regularly, you have least complication rate. So once in a while surgery is you are inviting a complication. Initially, selection of patients seems like a puzzle. It looks like a Lego when you do the surgery, but at the end, when you do the surgery right, you have less complications and more patient satisfaction. So in nutshell, proper exposure, inadvertent release is not allowed. Confirm the diagnosis. Thinnest possible tibia. Spigot Science is a miracle. And absolute gap balancing is a prerequisite without overstuffing the implant and playing any with. It has nothing to do with alignment. So here there is nothing like alignment. You feel the gap. When your deep MCL is intact, you can't do anything. So you cannot change alignment, which is the soft tissue governed procedure. So never tether your soft tissues and feel the bearing. It will be a very painful uni and it will be easy to be revised. Thank you.